So we'll see who straggles in, but it's open topic today. So anybody have things they're burning, or you have a
Oh
big
yeah,
win the last week?
I got a burning one. I just got off the phone for a burning topic.
All right, hit us with it, Al.
It's not a happy one. We are Philadelphia is now part of the growing trend of hospital consolidation and limiting competition. Just got wind that the second largest health system in Philadelphia market is going to vendor and knocking everyone out. Massive massive blow to a lot of us. They expanded and bought so many hospitals that they're touching every company that exists and outside of two vendors, and it's really disheartening. It's not going to hurt me personally on the immediate business side, but literally like the three things we have teed up for 2026 are all at Jefferson Hospital. So,
So what does that look like, Al? So do they just wipe the decks clean and everybody has to resubmit for?
no. So this is so what ends up happening is, and very particular to the Jefferson Health system that expanded. They bought three hospitals outside of Philadelphia in what's the Pocono area called Lehigh Valley Health Network. And when they bought the Lehigh Valley Health Network, that was an 80% DePuy hospital. And the rest of DePuy, that's my old group, has a very small share of the rest of the hospital businesses. But because of the weighted number for those three hospitals and this new VP of finance that came from Duke, that's his reputation preceded his arrival. His intent was just to do this. He's anti-industry, he's anti everything. He views us as just kind of whipping post. And so they're not even their RFP was a scam. I mean, it was just all it was worthless. His intent was take the weighted current business and just negotiate hard with DePuy and Zimmer. To think about the Rothman Institute no longer allowed to utilize Stryker within the Jefferson Health system, you wouldn't. I mean, you like they're going to tell Bill Hozak that he can't do Stryker knees or hips in a Jefferson facility. They're going to go 90-10. And I mean, you're not just talking about one small health system like, hey, we've got three hospitals and, guys, you can go play elsewhere, right? This is like it's University of Penn and Jefferson own Philadelphia. I mean, there's great, all the teaching institutions of years past, Hahnemann, Graduate, all those, even Temple, Einstein, they're just non-existent anymore, with the exception of Temple, and that's a very financially strapped hospital. So we're actually, haven't talked about this, but me and a friend of mine in Detroit are actively talking to DC and a lobbying group that wants to attack the dynamic. They want us to write a letter so they can submit it to the Department of Justice relative to these type of income deflating, limited competition for no reason. Essentially, these supply chain finance people just want to put a feather in their cap that they saved all this money. In reality, at the end, they don't save any money. Because there's just costs everywhere that now you're beholden to two companies that can basically do whatever the hell they want.
Are the surgeons employees there in that system?
Not at Jefferson. At
Okay,
Penn, yes.
got it.
Jefferson's had a kind of a handshake deal. Well, that's not even true at the Lehigh Valley network that I mentioned. They are employed. So again, that empowers them. But it's called like the Jefferson Enterprise decision, essentially. So their surgery centers and things that they're partnered with are left off of that. But you're talking about, a lot of these employed centers they're all Hop Ds. So you're not even having the arena of migration to play in, right? So it's a bad thing that's going on. not only across healthcare in general related to, these big United Healthcare, CVS Health, or all these other things that are being initiated to own the physician, therefore own the patient. But now you're talking about hospital consolidation and limiting our ability to do business. It's just, for companies, when you make decisions now, 100% the scorecard we kind of use when we're picking strategic surgeons or even distributors, number one has to be access to the healthcare system.
Yeah.
You cannot put a design chip, you cannot put resources into a distributor that are in markets that you cannot play.
Wow.
So
it's a microcosm. It's going on all over the country. Yeah, Raymond's got a comment question.
A little bit of both. Can you hear me okay?
Yeah.
Sure.
Let me start with the editorial comment. I don't know, it's just Raymond pontificating on something he doesn't know a whole lot about, but I just arrived at NAS in Denver today. I have no idea how many people will show up, but in a sense, I guess the thought is that for various reasons, exhibitors have reduced the amount of attention given to NAS, but is it because surgeons no longer are the decision makers, like you just said? If access is how we're going to survive as, startup companies or whatever, then why spend money on surgeons, and I hate to be so cynical, who really don't have a say? They're employees, and then you have these hospitals that are making these kinds of economic decisions. Now, that was one comment, or editorial comment, but I have a question. If there's an initiative to go to Washington and lobby and whatnot, what's the basis of their argument? Is there anything that, from a legal point of view, prevents a hospital system from limiting the number of vendors? I mean, in my mind, they have full right to do that. Now, the quality of the service may go down because then they are not incentivized. But what's the basis of the lobbying? Is it just a altruistic healthcare quality is going to go down, or is there some kind of legal reason why they shouldn't be able to do that? Do you know? Then I have a follow-up question.
No, we've gone down this path. So we spoke to a whistleblower lawyer related to some of the smoking guns we've found around the country. A lot of it, and then the GPO relationship. So it's kind of like a weird entanglement that if you look at the GPO relationship, the DOJ or the lobbyists we were talking about were surprised to hear that 70% of the administrative fees now to the GPOs are going back to the hospitals. Then if you look versus where it was before, where it was 70% going to the GPOs. So what they're doing, what that dynamic in itself is doing, is it's keeping elevated price levels at a certain point, because it's affecting that. Now, if we also talk about the Medicare dollars, and any rebates are involved or anything like that, they're often not being reported because the hospitals can't even keep track of what the rebates are and where the money's coming from, right? So if they're charging one thing and getting rebated back on the other. So we're exploring, but then in a very emotional way, it's about limiting competition and affecting people's lives.
Yes. So
restricted trade.
Okay, so my third comment was actually going to be my agenda item, but I think it dovetails pretty well, unless you think it's too much of a rabbit trail, and we could talk about it later. But this is an aha moment for me, and I was curious if the rest of the group on this call is aware of something I just learned of yesterday, but maybe I'm late to the game. Of late, the vendor, or there's something called Simpler, which I guess is part of Lumiere or something, or it all gets confusing to me. My sales guy takes care of all this, but he's saying that they are now charging a $200 a month fee just to have the privilege of applying for a VAC committee with no guarantee that you're going to get in, but you're having to pay a subscription fee for the privilege of maybe getting an opportunity to get approved by a VAC committee. And so and then they also charge the 1099s by product. It's another version of
Extortion.
rep tracks and extortion. Yes. So I don't know whether that's a separate tangential comment, and maybe it is, but I just wanted to vent and find out whether if anybody else is aware of this new added cost to just even have the privilege of being submitted on a VAC committee. Is this, am I late to the game and everybody else is aware of that, or is that new?
A little bit. So it's a major ongoing movement on LinkedIn for the last year and a half to 2 years.
I'm not talking about rep scrubs. I'm talking about.
I'm not either. We're talking about credentialing. It's all wrapped up because rep scrubs are owned by, the credentialing systems. So they're accessing our data and they're accumulating our data of where we are and what we're doing and who's checking in. But the credentialing systems have been on our radar forever. And there's a couple of organizations. There's a young lady that's starting. There's a couple of people out there that are starting, a different version of that. That's less extortion and more actually bringing more value to the facilities. But yeah, it's
called Simpler Spend, and it has nothing to do with getting the credentialing. It has to do with giving a company the opportunity to get before a VAC committee. So it's like you have to pay a subscription just to even get into the VAC committee at a hospital.
I'm sorry, Raymond. I went on a tangent myself. I did not listen to you clearly. I am not aware of that. Is anybody else aware of that?
No, not on that one.
Raymond, I
Dr.
would
Brian.
ask Copeland about that. Copeland will know.
Is he on this call?
No, not today. He's not on.
Yeah, I was thinking about him. I was shocked. So we're going to have to pay $2,500 plus $200 a year, or for every application, just to have the privilege of maybe being told no. I'm like,
likely being told no.
Right.
Hey, can we
it's a mess.
Can we go back to the point about the hospital situation that you were talking about a few minutes ago? Is kind of where I wanted to add 2 cents. I mean, I think we all have ideas about implants and who should have access to which implants and whatever from a corporate perspective. But I think if I were going to be involved in a lobby, I think I would play the patient's outcome piece, right? Because I wouldn't want a surgeon who's been operating for 30 years or 20 years or 10 years or 5 years suddenly now being forced to use another implant. And you could say on paper, these implants are all the same, but it is really the basis of how comfortable the surgeon is with the product that they're using. And the fact that now some hospital system is going to mandate that a surgeon uses a specific implant, I think is dangerous. I think it's dangerous. And like I said, if people ask me what kind of hip or what kind of knee they should get, I've got very strong thoughts about it. But in the end, I'll say, you got to feel comfortable with the surgeon. You've got this, the surgeon trumps everything, right? So if you've got a patient or a surgeon rather who's using a product that he's never used, the cuts are going to be different. The implant philosophies are a little bit different. Just the whole way it's all set up. And I would play the danger card, warning, 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 danger, patient safety. And I would think that patient outcomes are going to disintegrate at these facilities. So go step off my soapbox. That's what I want to say.
Well, in the old days, the surgeon would threaten to go across the street to the competitor.
And I wonder if they won't still.
Surgery center, but I don't think they have those options.
They don't have the options anymore.
They're gone.
Not as much, huh?
Yeah.
No, especially if they're employed, they can't, right? And
certainly not employees, but don't they still have power? I mean, they can still leave, right?
I mean, that has to be against their contract, their employment contract, being forced to use something that they're not properly trained on.
Exactly. And okay, we can bring in and we can do training, but that doesn't replace 10 years or 5 years or 20 years. I'm thinking of Hozak and, those guys. It doesn't replace all of those years of comfort. I mean, they can put in a total hip, total knee in their sleep. And now they're going to be forced to do something that, has a different design philosophy than potentially what they think is right. So.
I don't think this is going away. And I agree with Al. I think Raymond needs to pick hospitals and MSAs where it's more friendly. I think you just literally, you get out of those regions.
Right. Yeah, I've already obviously thought of that. I have one situation going on right now, which is great on one hand and terrible on another. I have a surgeon who is an employee who has actually postponed her patient until the hospital will allow us to, or allow our implant to go in, which I'm like, oh my goodness, I feel awful for the patient, but she's fighting the battle. I don't know how it's going to turn out. So I'm thrilled for that. The surgeon has got that loyalty and interest, but I'm very saddened for the sake of the patient.
That's what, 12 to 18 months, right? To go through the VAC committee and all that stuff.
Well, she's trying to fight a one-off approval in this case, and even that is a struggle. And so, but she's an employee, and so, but I commend her, kudos. But I also feel awful. There's a patient behind this, so there's another. I don't know. If it's a danger thing. It probably isn't in this case, but it's a very much of an inconvenience for the patient.
It's a lack of competition. I think Al said it best. It's you're eliminating competition, which is bad
Right.
for, yeah.
Yeah.
Yeah, I don't know if you guys read it or not. I just wrote this article, 14 contrarian truths in our industry. And one of them was sales is the hardest part of building a company by far now. I mean, design, regulatory, FDA funding, those things are easy compared to sales. Sales has gotten really, really hard because of these access walls. Stephen?
Dr. Brian Blackwood did a talk at AUKUS on the credentialing side of things, and he's been the guy that's decided, let me go after all these companies. And what he has found is rep scrubs and all this credentialing has actually just all been a rebate, essentially just a kickback back to each individual facility. So it's very interesting to see the simpler side. You're essentially getting a kickback to try to get a product, even just go to a committee. So he's really made it his mission to go after these corporations that are just essentially extorting us.
I'm sorry. Repeat the surgeon's name again. I missed that.
Brian Blackwood.
Okay.
He's
Boulder.
actually Boulder based, but he had a great conversation on it. Kevin Brown, we recorded it. Kevin Brown will probably be posting it.
Kyle, what are you doing on because you're developing, products and stuff? Is that, I would imagine that's your internal discussion when you're trying to figure out your strategic partners and stuff, where you're going to be able to go with some of your.
Yeah, I mean, North Shore in Chicago has put a full moratorium on any type of biologic scaffold coming to market now too. It's crazy, but yeah, it's definitely what we're trying to take into consideration of where to launch, when to launch, what the credentialing services are in those areas. Just relying on the distributors in those areas to help us out with it. There's also some distributorships that have contracts with a hospital, so you can fly underneath that contract. But it's definitely a concern right now. This one concerned me quite a bit. Now you're spending so much money and eating into your expenses just to try to get into a facility to have those meetings.
They're just adding friction. They hate new products and they hate the small companies, and they're just adding friction.
So Rep Scrubs has a case study on their website of the reduction in actual new product submissions on there. That's awful.
So who was saying there's a new RepTrax system that's got less extortion? Was that Al?
Yeah, her name.
Yeah, let's have them on BoneChat. That would be fascinating.
Yeah, she's good.
Cheryl
Blanchard. Cheryl, right?
Yeah, I know Cheryl. She's the CEO of Annika.
No,
different Cheryl.
Different Cheryl Blanchard.
Halbert.
Oh,
Yeah,
Okay.
no, Cheryl
Halbert. I'll put her link
Yeah,
in.
put it in the chat, and you put it in the chat.
She'd be great. She's getting out there too. She's really active on LinkedIn, and she was just somewhere. I knew she was at AUKUS, and she was at somewhere else where I was. But I mean, it's all by design, right? When I say so we just typed a letter to all the smaller OEMs, because I tried to engage distributors that I felt would be engaged across the country to help kind of join this alliance. We even formed the Alliance for Independent Medical Device Organizations. And nobody wants to do the work. And so me and Sean Milford were just working our ass off, and we're like, what are we doing? So now that it's come to affect me, it started with him in Detroit. I'm just going right to all the other orthopedic manufacturers I know and saying, like, we've got a group interested in DC to help us. Now we have to Laura Lund's and Raymond's point, we have to dial in what we're looking for and what's wrong with it and why hospitals limiting vendors, but it crosses over into the very emotional space of patients and insurance selections and where they can and can't go. So it's all a similar theme, right? That we're losing control. We're losing the ability to do business. It's not a free market. And we have to better understand the relationships as it relates to the Medicare dollar. Because I think that's where we can potentially tie in what it means to the taxpayer and to the federal, into the health of the health system, as it is, so we'll see. I mean, it's not an easy thing to try and sell somebody to get involved with, because it's like, all right, so
lobbying takes a lot of time and a lot of money, and it's hard to get noticed. Right, Raymond?
All right. Again, an engineer practicing sales without a license is very dangerous. But here's what I would like to propose, that in our invoice to the hospital that require a $200 a month fee just to be able to sell to them, we just add an administrative fee to the price of our implant or a surcharge or something. But I don't know how well that will fly. They'll probably laugh at that, but it comes to mind.
I like it.
Well,
Perfect
I had an idea that I was kicking around, putting on LinkedIn. I'm not sure about the consequences, but if every rep truly spent a week doing nothing but opening a box, that's it. That's our job. That's what you're paying us nothing for. We're not to be your staff extenders anymore. We're not to check on the schedule. We're not to go running for lost instruments. We're not to do anything. Our job is to open a box. That's how you value us. So that's what we'll do for a week and see how you operate. Because we truly, I'm Tiger, it's a thought. I'm not saying I'm going to put it out there.
Yeah, they've taken away the incentives. I don't know. I mean, Arthrex already does that, right? They got $50,000 box openers all over the country. Right?
Yeah, but those guys they're still hustling. They're still checking schedules. They're still keeping an eye on what's going on. Hey, doc, that room's not moving. Hey, doc, they're missing this. Let me run. Like that's happening every day. We're all doing it. We're staff extenders. There's no gray area.
I think the whole sales model needs to be rethought, and I have no idea what the answer is. Kyle, go ahead.
And so a couple of things that I'll note from more of the front end part of things, where my focus tends to be, you guys, all this conversation is around what happens as it gets into the patient, and I tend to be thinking more about what happens on the front end. And there's two important things that come to mind. First is when you start building your model, your business case, your market strategy for new products, it's becoming baked into the cake that you're going to go to friendly places, easy to get to, surgery centers, part of the family, and it's going to take you a year or two to start phasing a product out into the broader marketplace because of all of these dynamics. And so what that means is that everyone is guaranteed to have a delayed adoption of something new coming into the market. And then, I think the other thing that comes into play there is that patients end up being funneled into places where new technologies are available if doctors think it's needed. So, if you've got surgeons that are employees or part of a big hospital system, and they know that they're never going to get something approved, but there's a new technology that their buddy across town is doing, they're just referring patients out. And that ultimately ends up being lost business to the hospital that they may never even be getting a sniff of and may not even be realizing that they're losing it. But I'm sure that that is happening at scale.
Interesting. Interesting.
If I can interject on that, so Stryker, when they came out with their hip arthroscopy table, came out with a full-blown marketing program, and the table itself was better for patient care. There was no post, and it was significantly more expensive. But the marketing program showed on average a 30% increase in patient coming to them for those hip cases. So surgery centers justified it just because they knew that they were getting more patients coming back. So it kind of goes to your point of if there's new technology and you can find a way to potentially market it, it should help patient, population coming to you. There definitely needs to be some type of study that can help on that from the hospital side. Say, hey, if we're not adopting new technology, we're losing money significantly. I don't know how anyone feels on that one.
I think the delayed adoption is a really important point because I see a lot of startups. It affects their cash flow. They have a new product. They get regulatory clearance. They go to their friendly customers first, and then they try to go out to other places in the country, and it's impossible. And they get into that. Surgeon says, "I want to use your product in Phoenix," and it takes 18 months to get any cash out of Phoenix. And it just really hurts cash flow for the little guys. You got to pick your territories, I think, really carefully. And I don't know what the answer is. It's tough. Sales is the hardest thing. Who would have guessed?
Maybe it's rural first now.
Yeah, well, the margins aren't as good usually. That's one of the things. Raymond, are you selling outside the U.S. at all?
So he said rural, not OUS.
Oh, rural. I thought you said OUS.
No, but and the reason I was going to say, actually, rural has better pricing. Okay, and so if you find the right place, and there are a fair number of places, I've had mixed results as far as OUS. To answer that question, I think the jury's still out for me on that. I'm not giving up, but the U.S. market, obviously, there's a lot of advantages and set turns and things like that. But yeah, you got to be scrappy, I guess is how I'd put it.
Yes. Wow. Yeah, this is a downer subject, but it's so important.
I said it wasn't going to be pleasant. It just was very topical. I started the day off great, and then I got a phone call, and I probably would have came up with a better topic to start.
Gee whiz.
I know, buddy. I know it's unavoidable.
So I don't want to name names, but it's a really prominent surgeon texted me a couple days ago and said ortho is dead. Said it's not the same anymore. Everything's hard for everybody. But I didn't want to push him on that, but we're going to talk about we can talk about Globus just killing it right now. They're eating the world. And then Therese got a huge haircut. We could talk about one of those two things.
Globus and spine.
Yeah, they're mostly a spine company, but they're they've got trauma.
Dabbling into hips and knees.
Dabbling into joints, yeah.
No,
Even sports now too.
$11 billion company, and they grew at something like 30-40% sales year over year. I mean, just insane. They're killing everybody. I don't know how they're doing it.
Well, how is that possible if ortho is dead and if no one can get anything approved in any hospitals? So one of those two pieces of information is wrong.
Right, exactly. And I think what the doctor was saying is ortho has gotten really hard for little companies. I think that's what he meant because he's a startup guy.
Not Mark Freumsen, is it?
What's that?
It's not Mark Freumsen, is it?
No. Yeah, but I mean, does Globus have locked in access to big hospital systems and nobody else has? Or do they just have 1,000 products?
So I'm sorry, I didn't read the article and I kind of scanned that. But is that 30% NuVasive revenue, or is that already year over year outside of that? I can't remember.
Here, let me look. Let me
It
look.
can't be. It can't be recon. I know what's going on there.
Well, yeah, but yes, I agree with that. But
hip and knee.
but NuVasive, when did they buy them? A year and a half ago. And so if you're comparing without NuVasive versus with NuVasive, then it's really not that significant growth. Yeah. But I don't know. I didn't look at the numbers to see whether it's with or without NuVasive a year ago.
Well, so in 2023, their revenue was 1.6 billion. Last year, the revenue was 2.5 billion. So, I mean, that is a massive.
But that was NuVasive, probably.
That's probably a NuVasive bump.
Yeah. And so are you comparing? What I'm trying to understand is when was the NuVasive acquisition? That was a year and a half ago, I think. So it may be, you're right. So it could be that if it's over a year, then that may be real growth on both sides.
And you got to imagine if they did it right, and if the merger of those companies was aligned with complementary product portfolios, you would think that if each company was $1 billion company, that together they can become a $2.5 billion company, because they just get same store sales across both sides of the product line, right? So they each can grow because of the other things that each side of the equation can offer. But that's still 30% when you're talking about 10 digits is pretty good.
Yeah.
Talk about Treese. What they did layoffs with Treese?
They've got to do layoffs. I mean, their stock's in the toilet. They're down to, I mean, their market cap is now equal to their annual revenue, like 220 million. That's insane. That is insane.
Have they just gone too long without turning a profit?
Everybody's got their theories. I think I have two theories. One is they taught the world about bunion's a bigger market than you think. And so now there's a ton of competitors. This is like SI Bone. SI Bone was the first one to do the SI fusion, and now there's 50 companies. And they taught everybody about the application. And SI Bone's always struggled since then. So I think it's competitors. And then the second thing is I think they're just late to develop a whole bag worth of foot and ankle products. Like, I mean, look, the experiment was Paragon versus Treese. Paragon had a full bag of 100 products, and they got acquired for $1 billion. Good for them. Treese kept going.
They wanted to own the first ray.
What's
that? That was their tagline, was they want to own the first ray.
Right.
Which represents 15 to 20% of the entire market opportunity when you get below the tibia.
Yep.
Yeah, the distributor, we've been approached, I think 4 or 5 times. We have a pretty robust foot and ankle for competitors. And, so cost, then becomes a driver, right? You can do the same procedure for less. And that's how we were able to take market share from them.
I'm working with a couple podiatrists on a project, and I on a calcaneal system, and I said, "What do you use for bunions?" "Oh, we use Lapiplasty." I said, "Well, why do you use Lapiplasty?" You go, "The products are all the same. It doesn't matter." But Treese just brings us patients in the door. It's a patient referral system that's better than anything. So we have to use Lapiplasty. I thought that was an interesting comment.
Well, they do. It is effective. We weren't able to convert one surgeon for the same thing, the same mention. But the catchment area is really congested in Philadelphia and New Jersey, and that becomes everybody else who's not involved with that. And then sales tactic you use where they're heading versus people who aren't seated at the table. And then you just start to whittle down their usage of Treese, and they just move on to somebody else.
Yeah. I think they're just late in filling out the bag. They should have started building, 10 products to sell 2 years ago, probably. I don't know. But that's what's,
Well, I haven't met a ton, but a handful of the Treese reps that I have met are not exclusively Treese. They're selling a bunch of stuff because even though it's a well-paid procedure, it's not enough to be standalone.
you can't live,
And as
level
ever,
one. Yeah.
and as everybody knows, when you're sharing resources like that, that puts an automatic ceiling on the amount of effort that you're going to get. And most of us have to deal with that. That's real life, but they're an entire company that you would think would have stood up a more viable business model for their reps to not have to be shared. And maybe it was for a period of time.
Yeah, that's one of the most underappreciated things. And I don't know a lot about sales, but I talk to these little companies and they go, "Oh, we got 30 1099s all over the country." Well, how often do they talk about your product?
30 people that spend 5% of their time on your product means you have
Less than
1.5
that.
people. Yeah.
Yeah, the sales reps are going to lead with whatever's the easiest to sell and whatever's the highest margin.
Yep.
Yeah.
Or ultimately the math is just how much money am I going to make per year on this product. That was the thing we ran into with Sonoma that was impossible with the clavicle. Was it was cool and doctors liked it, and they had 600 different customers try it at one point. But the number one surgeon in the country performed like 12 a year. You can't get somebody's attention when they've got to go put in a bunch of effort to do one case every 2 months with a
Yeah.
doctor.
I sold that Sonoma nail, and it was the easiest door opener that you had, and that's why you led
Yeah.
with it, because it was the easiest way into led to the most revenue in the quickest time. So thank you for that. We appreciated it.
That's
Yeah,
funny.
it was a great wedge product. It was just like, well, the next 3 broken clavicles I saw were 16-year-old boys, and I'm not doing surgery on them. So sorry about your nail.
Yeah, yeah, yeah.
Gee, Raymond, how many products do you have in spine now?
So we have, we are and my marketing guy or sales guy says, don't ever say this. Well, this is, we're a one pony company that does many tricks. In fact, our implant is called One Lift. It is literally one anterior lumbar spine cage that can be used in multiple access corridors. And that's the beauty, because oftentimes you need to make a pivot mid procedure, or call inaudible is what I sometimes call it. And having a versatile implant that allows you to get around anatomy and so forth. Plus, you can either have the patient in the supine position or the lateral position. So from an economic standpoint, by having just 44 SKUs, which is a typical size for an A-lift, you can do 3 different types of procedures. So it's really one product. Now, we are working on more stuff. And, how could a product development engineer runs a company not do product development other than this pesky thing called money, or lack thereof? But yeah, we're focused on anterior spine. And so we're going to continue expanding the bag and making life easier for that procedure. Did that answer your question, Tiger?
Yeah, perfect. Yeah, perfect. See, that's the other thing that a lot of companies don't do is you can stay small. I mean, you can turn a profit with 5 employees. You just got to stay really small, pick your customers very carefully, keep your inventory down, be careful who you partner with, and you can get to break even. It's a lot of people, the investors don't like the strategy because they want a company that's going to grow and grow and grow. But you can create a great lifestyle business, I think, with very few products and a really small team.
Just got to be patient, right?
Yeah, it's the long game. Yeah. One of my favorite companies is Icarus Medical, and I'm going to have them on BoneChat. But there's 3 engineers that came out of University of Virginia, and one of the engineers was an avid snowboarder, and he had he had arthritis under his patella and he couldn't snowboard anymore. And he was painful to get out of a chair, even though he's like 25 years old. And so he said, well, I'm an engineer, I can fix this. And so he started buying all these knee braces to try to, and none of them worked. And so he kind of Frankenstein together a patella offloading knee brace that worked for himself. And he goes, wow, this is cool. I can snowboard, I can jump out of a chair again. And he started, if I got this problem, other people have this problem. So he started selling it, created Icarus Medical. I met those guys 5 years ago or something. They were doing, like 3 guys were doing 200,000 a month out of their garage,
Hmm.
you know? And now I mean, I just saw they're one of the fastest growing companies in Virginia. I'm going to have them on. These guys are probably doing 20, 30 million in sales now. And I bet you they don't have a lot of people. Um, I mean, I love businesses like that. And he had a 3-part thing. He had prescriptions for custom braces. And then he also, where he went through physical therapy people, and he also did a direct to consumer. So people just buy it with cash over the website. And then the third thing, he created a partnership with Hanger Orthopedics, and they would bring him customers. And boy, they kept it lean. Anyway, Dave Johnson, Icarus Medical, I'm going to have them on pretty soon. I love those little businesses, those like lifestyle kind of businesses, self-funded, you know, profitable instantly.
Good for them.
I
They
love
they
them.
just yeah, they just posted they're hiring like 4 regional managers, I think, or in the
There you
process
go.
of, but I mean they to your point, they've been growing really fast. I think it's a great product. But Tiger, I have to jump. Thank you for doing this with Raymond. I will be stopping by your booth later. I'm in Denver, just down the street.
Don't have a booth. You
Oh,
can
good for
call
you.
me. Yeah, that's a
Yeah,
whole nother
yeah.
story. But
Well,
yeah, feel free to. I don't know if you have my number, but
I don't, but if you want to say it, I'll
oh,
take it down and text you.
sure. It's 352
Hmm.
262 9524. And I'm sorry, your name is?
Stephen Flutie.
Oh, okay. Thank you.
Yep. Yep. I'll definitely will grab coffee or something in the area.
Yeah, I'm
So,
here through Sunday.
perfect. I
Look,
live here, so
Okay, very good.
and look for
yeah,
Andrea Davis is bouncing around. Look
oh,
for
Okay.
her.
definitely.
Yeah. I don't know who else,
Awesome.
what other bone chatters are there, but
Yep. I appreciate everyone. It's great talking to you. Take
thanks,
care.
thanks, Stephen.
Yeah.
Bye.
What else is burning? I shouldn't ask that question.
Well, I had a interesting meeting. If you look at we're in development on something that's going to be really good for ASCs. And one of the things about the hospitals, the Cleveland clinics, the Penns, the more and more hospitals have these innovation divisions, right? These things where they actually take ownership, partner, research, all that stuff that we all know. And the people who don't are the major ASC companies. And so a friend of mine is very involved with them on the funding side and consulting side. So I actually have a meeting next week with the CEO of one of and the chief innovation officer of a very large ASC company, um, to explore them venturing into that innovation world, especially because migration to surgery centers is so prevalent and it's so topical and it's where all the manufacturers and small companies want to go. They're traditionally have been downstream, right? So they would rather partner on a financially beneficial kind of like global contract. But this one company has interest of developing like an innovation arm
Hmm.
where they would actually have ownership of some of these
And
innovations.
how many, when you say ASC group, how many surgery centers is that owned by one entity? Is it like 10
They have 800.
800? Oh my gosh. And it's not private equity?
No, it's owned by a larger system that they acquired them. So they're
Okay,
still under the same umbrella of a larger health system. It's under the Tenet Health
okay.
network.
And are
So
they still stiff arming new products because they're
no,
part
no,
of
not at all.
it?
But
Okay,
what we're trying to do is I've kind of got a Trojan horse on this one. Yes, I would love to have them to take. We think what we have, and I'll Tiger I'll be circling around with you to show the group soon enough. But we think what we have is true relevant innovation that checks a lot of boxes for patient throughput, revenue increasing, and all these things within the surgery center. So, but I'm also interested to talk to them about what where they see their own revenue streams coming in this in their ASC space, that they own all these ASCs. And I'm curious to just get their perspective, because the worry is that the hospital executives who have retired with a pension are now being hired by the surgery center companies to now turn this fluid, bastion and panacea for us to do business into hospital bureaucratic, molasses. And I want to find out if there's intent to, participate in these things, or so it'll be interesting to get their perspective. But I got to control the laundry list of probing questions without giving away that I'm trying to really find out what their strategy is.
right.
Because it's all hospital executives taking these positions with leadership, and they're coming from a mindset of exact opposite of what we want for the surgery center market.
You're going to ruin it. Yeah. Wow.
That's crazy.
That's another point. A startup can make a living with ASCs only, right? You can have but your product's got to be designed and built for, no trays, disposable, no rep or light rep. But you can do that. You can make a living off of ASC strategy only, I think. I'm not sure any medical device company's done that yet.
Well, they're trying, and they sell them on it. Right?
Yeah.
Stryker does the best job, but that's locking them into capital offset, right? Capital purchase offset. So it's not easy. They're messing with things, especially as hospitals convert their failing surgery centers into hospital outpatient departments, which essentially means you're doing business with the hospital again.
Wow.
That's not a happy topic.
No.
Now you're full of joy today, full of joy.
Well,
Yeah,
I guess
yeah.
let me spin the happy side of that then, Al, because I've always wondered to a certain degree why a hospital system, why a group of surgery centers, why they wouldn't just effectively pay themselves by taking the step and investing in creating their own product that they then could sell to themselves at cost and have it be, the math would eventually make sense, right? Just to use simple numbers, it costs you $1 million to develop your own version of an Actis stem. And instead of paying $4,500 for it, you pay a raw cost of $700 because it's owned by your company. Now, there's going to be conflicts of interest and stuff that get embroiled in that come into play to some degree, but there's got to be a way around that would allow you at some point to pay yourself back pretty handily, I would suspect. Is that the type of thing that you're talking about, or is it purely ownership of equity and innovation that then they can sell to the rest of the world, and it doesn't have a revenue target improvement in the surgery center?
Yeah, so when they would own part of our device, right? But it's not an implantable, so I'm clean on the implant side of things, right? This is a device to help them throughout the day in surgery. It's not billable. We're not billing Medicare. It's a cost that they need to spend. It's just that ours is better and ours is less, and ours checks all the boxes that their existing market leader presents the challenges to them. So implant ownership is a whole different thing, man. That goes back to the pods and conflicts and all that, Kyle. I don't know, brother. I've never been in charge of an implant to go down that path. I've just kind of made things as inexpensive as possible in our distribution side of things to be more attractive. But I don't know. See, ours, I guess it would be similar to, if they were to invest in digital health. So their big initiative right now, they think it's going to be digital health, the electron EMR systems and patient throughput systems and those things. That's where they're looking right now, which is why I'm able to get the opportunity to even talk to them, because they think that's the path they're going to go, which is probably the right path. Then therefore utilizing their own system that they have ownership with or co-develop with their innovation department to then institute across their systems and save money. But on the implant side, brother, I don't know. I know there's conflict. It hasn't been relevant for me to be a subject matter expert on.
Yeah, Raymond?
Earlier in this hour, somebody said the migration to ASCs because the larger hospital systems won't allow innovation in. So Al, is your angle, I'm not sure who's pitching who in your meeting, but my question is, if you're pitching them, is your angle that in order to help them grow their ASCs even more, if startup companies with cool, innovative technologies would do some kind of exclusive deal at the ASCs, would that be attractive to them? Again, I'm a little not clear on what you're trying to do, but I'm just trying to connect some dots here.
So they are the customer that everybody wants. We've talked about it here is where I'm going to be able to play, right? Regarding the hospitals, yes, there's a whole different economic thing with failing ASCs, but in the most part, all we're doing is talking about migration of elective procedures and maybe, small trauma cases to the surgery center. So if that's the ultimate customer that the OEMs and the major orthopedic companies across the board want as their customer pipeline, because we're all trying to be ASC solutions, then if the ASC company that owns 800 centers across the United States have an equity stake in that, will those startups then be more attractive to somebody who would want to acquire that, right? So if Kyle is developing something that the ASC ownership group are able to then invest in, his eventual acquirer, he's already got a pipeline of where they want to go. So yeah, it's nuanced and it's not probably going to be clean. Our device is going to be easier because it's very operational.
If you're willing, I'd be interested in hearing how your meeting turns out and if there's any opportunity for others.
Yeah, I got some thought to put around how that lunch is going to go. Yeah, he's coming into the area, and my buddy does raises money for them and is involved in private equity on the good side, though. He's a consultant with the good, a very good company. So yeah, I mean, I wouldn't have mentioned it if I didn't think it could be a future BoneChat discussion.
Good.
The hospitals have these innovation centers because they want to market better to patients, right? They want to say, we've got the new robot, we've got the new minimally invasive surgery that nobody else has. Isn't that the purpose of the innovation centers, like at Cleveland Clinic? Who knows?
Yeah. I mean, they have ownership, like they have co-development agreements with a lot of things. I mean, I don't think for robotics and different things, I think it's more innovation that they want to like partner with, smaller organizations that are innovating. But there's a lot of competition for that now because there's a lot of money out there related to the R&D, elimination in the big five, right? They're just
they don't do R&D anymore. They give up. Yeah.
Education and M&A.
Right.
So we'll see.
Interesting.
So just one last comment about that medical education. So we're pitching something, and Depew is coming to, they want to talk to us about, all of their educational events. So listen to where their budget is. They execute 650 educational events per year, training over 2,500 surgeons. So they want to talk to us about, helping out with one of the problems they have with that existing market leader versus our solution. But 650 educational events.
2 a day. If you get rid of the weekends, it's 3 a day. That's incredible.
Amazing, right? I mean, that number, and this is the person who runs that for Depew. Like, that put that data point in this morning into an email. I was like, holy shit. If you want to know, it's called indoctrination. That's what it's called, indoctrination.
Yeah, so of that, you're going to have probably 150 of those events or more are going to be individual things, some sort of one-off, some sort of visit. Maybe even more than that. Maybe upwards of half of them are going to be very, very small group, because you said 2,500 doctors and 650 events means they only average 4. So you got an event with 10 or 15 people every weekend, pretty much year round. And there's going to be maybe more than one per weekend. There's going to be, say, 40 to 60 of your events are going to be larger. The majority of them are going to be smaller. So I'd be curious, Al, to see how they calibrate, like where there are needs to help. Because as you can imagine, the bigger the event, the more that goes into it, the more cost, the more planning, the more execution. But if they have 5 times as many small events, maybe that's actually where they need the most help in managing logistics of that much more volume. Maybe both.
Well, and if the 650, if I look at Depew that have now gone back to their distributor model, if it's 650 under the Depew marketing educational budget, right? How many are getting done with one? Are we just talking about a consulting fee for a surgeon who trains one person? Is that considered part of their educational event? I mean, the way he framed it was they're running 650, right? So you're right, Kyle. I don't know what's captured under that number, but
Sounds like a lot of local Marriott. It's in a neighborhood somewhere. Yeah, that's a call for John Alleman's Overland mobile training thing. That sounds like Depew should be all over
Yeah,
Overland.
they'll also be counting, because I was in the education team for a couple of years there. They'll also be counting webinars and other online events are counted in that as well.
Probably
okay.
dinners too, right? With
Yep.
all of that is part of that.
yeah.
So,
Well, we'll see. I just thought it was an interesting number.
It's still an interesting number. It's just made up
Big
of a
number.
bunch of different contributors for sure.
No. I like it, dude, because you got to look at it. Nothing's absolute, right? If you just slow that down for a second, and if something makes an impact on you, like, wait a second, just think about that a little bit more. So I like that perspective, brother.
Interesting. Wow. Yeah, the big guys have so much scale, and that's how they win. Just massive scale. All right, we're up on an hour. This has been fun.
Sorry to bring the mood down for half of it.
luckily, it's a sunny day here, so it's all good. The sun's shining here, so it's okay.
Hey, I'm a Philly guy, man. We're just negative. We wake up annoyed at the world and pissed off at half the people in our world. Like that's just our nature.
That's funny. Awesome.
Well, we're glad you could vent here then. Good to talk to you guys.
yeah, that's what I'm here.
Yeah,
Next
take
time.
care.
All right, see you next
See you
week.
later.
Thanks.
All right,
Bye.
guys.